where I was going.
Yes.
No matter how
and so
you screen.
one of the ideas, so there are many other people working on, is to use things like molecular imaging, where you use a specific, this is mostly hypothetical, but partly under development, but it still needs to prove its usefulness. But let's say if your triple negative aggressive cancer would have marker X, and you would be able to make a traceable compound that you can use at time of screening to identify those tumors that is much smaller diameter, then you will be where you want to be.
Yeah.
But first of all, you need then to be able to have such a compound for molecular imaging that's really reliable. And secondly, that needs to be implemented in daily practice, but there are certainly people working on it. Also to be able to distinguish on that end the most aggressive tumors, but also on the other hand, the ones that are actually not aggressive at all, like the idle ones or even lower stages of aggressiveness.
Yeah, I sit in the lab and I kill breast cancer cells with, I'm supposed to be on the cutting edge of the new drugs, but it occurs to me that if you maybe just were on the cutting edge of the new screen, you might be able to catch a lot of the bad stuff earlier. And maybe the drugs out there are just fine, and you need to do some mixing and matching between patient and drug, even still when you have that new information. But in fact, without that new information, you're only getting these patients when it's too late, or when it's very grim looking.
Yeah, so the really gain to make is to identify cancers at the earliest stage.
Yeah.
Then that will have the most impact.
Yeah. But there must be a way to grind through a bunch of the data that's already out there that says, for example, if you believe it's an interval cancer that was invisible when it was small, at some frequency you should, just because the intervals are all over the place in different patients, you must catch those small things. You must see those and deal with them. And maybe if you did, rather than the study of the giant tumors, you did a study of only the very small tumors that had the right sort of molecular signature for poor prognosis, you would already see that a certain percentage of those were fine, a certain percentage of those were not fine. I mean, you could play the sort of same games you're playing with the giant ones, but do it with the smaller ones, and see really if I should come out of the lab and go be Nola's technician, and we just like ramp up some screening, or whether what drugs. What's missing?
But I think also most of those, the reason I think why also I spy patient eligibility is like of 3 centimeters and larger, and now it's down to 2.5. It's also because all these things are relatively new in the clinical practice.
Yeah.
So you need to select or identify a patient population that is amenable to these sorts of trials. And if you are one step further, you'll bring it down to 1.5 centimeters or maybe even 1 centimeter. And that's also image.
Yeah, so one comment I would make there, so thinking about it, we're almost going in the direction now where we will reduce screening. And that might be a mistake because then we don't have anything to look at, as opposed to figuring out how to take current screening and not necessarily act on everything, but to understand what screening, what did we screen that's associated with non-risk and so forth, and because if we don't have the data, then we won't know that either. I mean, I tend to think that this right now this was almost anticipated, that if you take this general population screening, one size fits all, everything we're learning right now says one size doesn't fit all. So we're finding all the reasons why screening is doing poorly, or it's actually hurting some patients. And so the question is how do we do smarter screening, better screening? How do we define it? How do we figure out, there's screens and then there's screens. Not everyone you screen and you find cancer should go to surgery. So maybe there's watch and wait type screening and surveillance. So, I mean, I guess when I'm thinking about it, there's the cost implications, and then if you add any of the newer imaging technologies, that cost is exorbitant. So you won't screen large populations, but if you do some targeted screens or some sequential levels of screening, I think that we'll learn more about it.
When you reach the metastatic stage, you have a particular profile, a gene profile, gene expression profile, but that's already after an event has occurred that actually gives you that particular profile. So are there any unifying factors, such as a global turn-on of specific genes that you can put into your screen that would, looking at these patients temporally, that you could identify when that is turned on before the cells become metastatic?
So from the imaging targeting point of view, and general, I mean, I think the whole dynamics of any of these questions is just another level of, you have static information in the settings that you collected the data, and then the natural question is there some dynamic aspect to that that actually gives you information, either progression or just static tumors that are not going to progress. So, what Laura mentioned that some of the things we would anticipate that there will be these very specific imaging techniques using radionuclides that will really map receptor targets and specific molecules that might be used in the way that you're referring. But other tissue-based tests, I don't know.
Well, even in doing the microarray analysis, you have a particular genetic profile that's associated with metastatic tumors. So,
so far, I think what people have been studying is that the overall biology of the metastatic disease in the patient and her primary disease is very comparable.
mm-hmm.
There might be changes, I mean, this is always a debate around this, but there is a certain wiring of that tumor that remains the same in the metastatic disease.
Right, but you showed a slide of specific genes, the metalloproteinases that are activated.
Mm-hmm.
Now those are specific markers for invasion and recolonization, so to speak.
Mm-hmm.
And so there must be a subset of those markers that could be identified that might be turned on globally through some kind of homeobox mechanism that you can identify early on.
In normal tissue already.
Right.
That would be ideal. That's how you'd feel. That would be your susceptibility.
Exactly.
No, but beyond genes, there may be other things. People who have chronic infections or people who have a certain immune environment. I mean, there are maybe some things that we aren't finding, because people, the same genetic profile can have a great response or not. So I think we have to, and it could be we just aren't looking at the right genes. That's certainly possible. I mean, Nick looks like that's over to show that may be something that's sort of important. But it could also be some interaction with your inherited ability to mount an immune response.
Mm-hmm. Or an epigenetic factor.
Or an epigenetic factor. So we don't know. And I think it's important not to be, we don't have the answer, so we shouldn't be sure it comes from one place or another. And keep an open mind.
What's the most likely scenario in how clinical practice will change as a result of iSpike 2?
Depends whether we're successful. Well, I think the one thing that clinical practice will change, clinical practice will change because we'll be able to test. Even if these drugs don't work, we'll find out much more quickly. I think that what we're hoping is that we'll drive down the cost of drug development and move the testing and finding out whether your agents are going to work way farther forward. So well before you put in $200 million. So by testing, by investing maybe $5 million or something, you could find out whether or not, or $10 million, whether your drug's going to work. So you would be increasing the willingness of companies to take risk and to really look at things in a different way. So that, I think, and finding a way to develop agents or test them in a much more timely way. So having our knowledge term not be 10 to 20 years instead of having one FDA-approved drug every 10 years that we might have, 100 or something, I don't know, but completely different. So that would change. Whether or not we're going to change clinical practice totally depends on whether these things are successful. We're hopeful, but we have no idea.
I think it's partly also, I think the whole process of things that need to change clinical practice, I think patients are also very important in it.
Yeah. I mean, so when everyone said, oh, well, we don't want this, then you can't do this, and the patient said, well, wait a minute, it's for us, we want it.
I think there are two aspects. So the patients are important to express what they actually want, But on the other hand,